We would like to move ahead to our next session. And the next session chairperson is Dr. Prakash Ramamurthy. May we have you on the stage, please? Dr. Prakash Ramamurthy, and the panelists are Dr. Chitra, Dr. Sharmila, Dr. Amalur Pavanathan J. I'd also like to request Dr. Nihar Ranjan to please join us on the stage, and Dr. Balakumar S. to please join us on the stage. The topic of discussion, the topic for this particular session is venous ulcer. Venous ulcer, chaired by Dr. Prakash Ramamurthy. Over to you, sir.
Check. One of the most anticipated sessions of the conference. Venous ulcer burden is a very big burden for the community, and I have had patients whose marriages have broken up. One patient whose marriage was fixed, the bride refused to get married, and a lot of social issues are there. So we are very keen to see what our panelists are saying. Most of the panelists are going to be online. I think Nihar may be the only one who is going to be offline. Going to do the live presentation.
Meanwhile, we'll just take a moment and request all the rest of you to kindly be seated. Those of you who are in the groups, you are requested to please take your seats. Requesting all of you who are moving around in the hall to please take your seats. In due respect to our speaker, chairperson, and our panelists, I would like to request all of those who are standing and probably moving around to kindly be seated. Please take your seat. Thank you. Thank you so much. Over to Dr. Prakash Ramamurthy. Over to you, sir. Over to the chairperson.
The first presentation is by Dr. Wool. Are we going to have it online live or have it recorded?
Virtual.
Hi everybody. First of all, I would like to send my warm regards to all my Indian friends, and very sorry and be very sorry not to be with you in the Vicon. This talk is about the transosseous perforated veins of the knee, and you can find it in Phlebolymphaology. It is published online. So bony perforated veins of the knee are commonly responsible for reticular veins around the knee, but they are underdiagnosed by the sonographers, and they could explain why the injection of these cosmetic lesions are frequently leading to recurrence. The aim of this talk is to bring anatomical evidence of these perforators, which are frequently missed by sonographers. So outline will be anatomy first, then CT venography, duplex color, and finally discussion about phleboarthrosis. So anatomical evidence was brought by Giro some years ago. The technique is a latex injection of fresh cadavers, veins in green, arteries in red, and anatomical slicers of half a centimeter thickness. Here you can see an example of these slicers with the green latex, which is between the condyles here, shown by the white arrows. On the right, you can see the latex in the spongy bone of the tibia bone here, and the perforators on the artery aspect. The arteries are in red and the veins in green. Here you can see a lot of latex inside the spongy bone of the tibia. You can see a perforator on the artery aspect and also in the posterior aspect of the tibia. And this is very nicely shown here with the holes in the bone here. And you can see the popliteal artery, the popliteal vein. And this is showing the junction between the popliteal vein and these perforators, which are going inside the spongy bone of the tibia. So in summary, three main locations of these perforator veins: anteriorly around the patella, posteriorly in the condyle groove, and also posteriorly in the tibial epiphysis. The CTV assessment is showing also those perforators around the patella, as you can see here on the left, and also laterally to the patella on the right. Image brought by my friend Overa from Argentina. The same is shown also in these images at the lower thigh and in the tibia area, and also around the patella by the yellow arrows. The duplex assessment can show this kind of images, which is brought by Vincent Cribassa. But this is very important to differentiate these perforator veins from the tibial diaphysis perforator veins responsible for varicose veins, as described by my friend Adrien Ramlet in Phlebology in 2016. And you can see really nicely the hole in the tibia. It's the mid-tibia bone and the anterior aspect of the tibia bone at mid-leg. Regarding the discussion, it's important to talk about phleboarthrosis, because we link that these perforator veins are linked to the so-called phleboarthrosis described by several German authors describing a phleboarthrosis complex. And moreover, several case reports have been described with the improvement of the inflammatory components of the knee arthrosis after treatment of the varicose vein, as shown by all these authors. Agus R. Krieg. In particular, Krieg made a very important study with a lot of cases showing that very frequently you have a chronic venous stasis of the leg, also of the whole limb, a post-robotic syndrome, and in all these cases, you see that 75% of the cases were improved by compression therapy. Another important study is brought by Malé Patel and Rory Verghese in the Indian Journal of Surgery recently, and they show that most of the knee arthritis are treated by orthopedic surgeons, and the underlying diagnosis of CVI is frequently missed. So the take-home message number one will be that before treating telangiectasia and varicose and reticular veins of the knee, the duplex is mandatory, looking for bony perforator veins, in particular around the patella. The second message is that all patients with knee arthrosis is mandatory to look for a venous insufficiency and treat it before the arthrosis. Phleboarthrosis is a common state, common feature, and often misdiagnosed. Thank you very much for your attention. If you are interested by anatomy of the veins, you can ask for my Atlas of Venous Anatomy. Thanks again for your attention.
Thanks for a brilliant presentation, Dr. Wool. We'll take the questions towards the end of the session. Can I call Nihar to do his presentation? Nihar? The second person.
Good morning, everybody, and thank you. And thanks the organizing team and the scientific committee to give me this topic. So all we know that different stages of chronic venous disease, the last it can lead to leg ulcers and recurrences. So what are the stages? All we know that it starts with skin redness and inflammation and complete full thickness of defect of the skin, most particularly in the ankle region. So venous a leg ulcer statistics. It is published recently in 2013 that venous leg ulcers require an average of 24 weeks of healing, and recurrence is found once or multiple times in 15% to 71% of cases. So yesterday in the nursing presentation, one staff nurse from CMC Vellore, she was presenting on the quality of life in the venous ulcers. So I was saying I was there in the judges panel. I was saying that we have to tell the patients that recurrence is very high. So how to prevent recurrences? So to include in the studies or the subsequent. So similarly, healed ulcerations possibly can have 5 years recurrence rate as high as 40%. And the prevalence of venous leg ulcer increases with age, with rates of about 8% in patients more than 80 years. And just now, sir told about, Professor Wolf, about phleboarthrosis. So more when age advance, the venous ulcers also increases. And very important is the management of venous leg ulcers consumes considerable resources in healthcare system. And venous leg ulcer is the most advanced form of chronic venous insufficiency. And the standard treatments are compression bandage, wound moisturization. And in the case of venous leg ulcer, standard treatment failure, advanced therapy should be considered. So pathophysiology, all we know that extravasation of the fibrinogen that leads to leukocyte activation, adhesion, and migration. So this is the old CAP classification. So 2020, what is added in that? You can see here recurrent varicose vein C2R, and C6R is recurrent active venous ulcer, and 3 subcategories like corona, phlebitis, and pigmentation of eczema and lipodermatosclerosis or atrophy blanche. So the management of the wound is apart from the reduction of the venous hypertension, like by doing endovenous laser or radiofrequency ablation or open surgery or glue, apart from that, how we'll handle the ulcer treatment. So you can see risk reduction, medical therapy, and different surgical therapy. So compression therapy, all we know, we should not use in the ischemic limbs, and the pressure should not cross the arterial pressure. So the pressure should be less than around 40 millimeter mercury pressure for the venous ulcers. So different compression therapies are there. These are all traditional things, intermittent pneumatic compression. So advancement in venous ulcer therapy. What are the advances? Ultrasound therapy, electrical stimulations, electromagnetic therapy, phototherapy, stem cell therapy, biologic skin equivalents, platelet-rich plasma therapy, oxygen therapies, anti-tumor necrotizing factor therapy, and negative pressure wound therapy. So what is time, tissue, inflammation or infection, moisturizer imbalance, and epithelial age advancing. So electrical stimulation, it increases blood perfusion in the area of the ulcer. Ultrasound therapy, there are 2 varieties. Is pointed is one of the adjuvant treatment used in venous leg ulcer therapy, where it gives one temperature and as well as the inflammation reduction and the flow to the ulcer area, blood flow increases. So coming to electromagnetic therapy is used as an additional treatment supporting wound healing, including venous leg ulcer. So it utilizes electromagnetic energy, and the device produces a field of effect. So there are 2 kinds, induces by the device, that is pulse electromagnetic field and continuous electromagnetic field. So photobiomodulation, that also it leads to cell activity and enhancement and restores the hemostasis. Oxygen therapy, although we know hyperbaric oxygen therapy, it increases the flow to the ulcer area. Negative pressure wound therapy, that also reduces the edema there. And platelet-rich plasma, we can inject around the ulcer, that improves the blood flow to the ulcer and it heals. Different biologics are there. Stem cell therapy, and stem cell therapy, all we know, the major sources are from the tissue, adipose tissue, bone marrow, and blood. It's a bilayer wound matrix, where it gives, it is semi-permeable silicon membrane, that collagen provides a scaffold for cellular invasion and capillary growth. So this device should not be used in patients with known sensitive to bovine collagen or contractin materials. This device is not indicated for use in the 3rd-degree burns also. So coming to another time again, the tissue, how negative pressure wound, inflammatory action by electric stimulation, all as I told you, and epithelial age advancement. These are another thing. Yesterday only here in our stall it is there, Q-Tubemate Servin, the original hydration response technology it gives, creating a safe filling due to outstanding absorption capacity. So ensures right moist environment for healing, avoid macerations. That is very important for the dressing of the wound. So coming to role of MPMF, all we know, it reduces the inflammation and increases the lymphatic flow, increases the lymph oncotic pressure, and increases venous tone by prolonging the activity of noradrenaline. So accelerates the ulcer healing as it acts as an adjunctive therapy to good local wound care and compression therapy and overall the favorable effect on the healing process. So to summarize, chronic venous disease is an element with high recurrence rate. So we have to reduce the venous pressure, then the different kinds of wound care by like compression therapy and good hydration to the wound bed and some newer gadgets we can use depending on the availability as well as any the selection of patients, very important. Thank you. Any questions, I think we'll discuss in the end. Thank you very much.
Thanks for finishing on time. We'll take questions towards the end. That's like watching a science fiction presentation. You covered a very comprehensive.
Thank you.
The next presentation is by Dr. Sri Kumar. I think he's also online. So is his presentation ready? Dr. Sri Kumar's presentation on wound care for venous ulcers.
We will move ahead to the next speaker. Looks like the speaker is not with us. We shall move ahead to the next speaker, to the chairperson, sir. The speaker is not with us, sir. We will move ahead to the next speaker.
The next will be post-operative management of varicose veins by Tapish Sahu. I think its presentation is also online. Yeah.
Good afternoon, everyone. I am Dr. Tapish Sahu, and I'm here to talk about the post-operative management of varicose veins. The intra-op management, the modalities of treatment, how you treat varicose veins in the best possible manner is as important as prescribing the proper medications and proper guidelines after the procedure is done, because the patients that come to get treated for varicose veins, basically they have low quality of life with respect to physical, social, psychological aspects which are being troubled by the varicose veins. So if we are not able to provide them a complete solution, even after a good procedure, the treatment fails. So the current endovenous procedures that are available, they are aseptic and percutaneous, but they may involve concomitant phlebectomies, which leads to small scars. There may be thermal or chemical damage to the vessel wall, which is primarily to its endothelium, which leads to a process of thrombus formation, and that is associated with an inflammation that accompanies these ablations, which may cause hyperinflammation, which has to be addressed properly by medication. There may be pain with because of the phlebitis or because of the incisions, which has to be addressed by proper analgesics. So what is the literature say about the regime that should be followed after the procedure is done? So first, coming to compression. So when possible, this compression is suggested after surgical or thermal procedures. This is the AVF or SVS guidelines. What they say is that if compression is to be used, it should be providing more than 20 millimeter mercury pressure together with eccentric pads placed directly over the vein ablated or operated on, provide the greatest reduction in post-operative pain. The SVS guidelines regarding the duration say that the best practice should be followed, which is the clinical judgment as to how long the patient has to be recommended this compression should be done. So there is no consensus with regards to the duration by the SVS, but there are various other papers that have been published. In these few studies where the pressure exerted by compression devices was measured, a strong pressure is always better than lower pressure, and in minimizing the side effects of treatment. The duration in various other reports say that early ambulation should be encouraged. The patient leave for home few hours after the procedure. At least 1 week is the time recommended for proper compression by ESVS and SVS. Ditching the stockings early, which may happen in Indian population by non-compliant people, which is all too common. This may stretch out the recovery process. The patient may have the recovery may be prolonged. The rationale of providing compression is that the empty vein technique prevents or minimizes superficial and deep vein thrombosis. It reduces the inflammation. It reduces the pain, bruising, bleeding, and hematoma, thus shortening the recovery time. In various publications, as I said, there is no consensus. Why is there a difference? Because the level of expertise of those who applied the bandage, what type of bandage was applied, the measured pressure range, the patient compliance, the technical mistakes, unwanted bandage related side effects like slippage or rolling occurred. So there was no standard method that was there in all the publications. So that's why the consensus was not reached. But what is the optimum that should be offered? The pressure exerted at thigh level must be higher than 10 to 15 millimeters mercury in the lying position and 40 to 50 in the standing position. Regarding the duration, the French study said that different surgeons apply long stretch bandages immediately, ranging to 8 to 15 days, followed by an elastic stockings, which is class 2 for another 22 days, that is up to 30 days, that's a month. 3 weeks of compression by elastic stockings are also recommended after sclerotherapy or any other venous procedure. On the other hand, other paper reports that there was no significant difference between no compression, between 1 week compression, 3 week compression. So there are contradictory reports available. One follows the best practice that the SPS says. So the consensus is that strong pressure is always more effective. The inelastic bandages exert high pressure and they reduce the unwanted side effects. There are few data available on optimal duration. The sparse data suggests, as per this study, that a strong compression for 4 to 7 days followed by 1 to 3 weeks with an elastic stockings, that's the most used, may not be the most effective, but that's what most of the people across the world are using. Regarding thromboprophylaxis, selected patient with a history of phlebitis, DVT, obesity, or known thrombophiliacs are the candidates where thromboprophylaxis should be offered. A significantly higher rate of proximal thrombus extension was noted in those patients with a history of DVT and when the GSV diameter which is being ablated is more than 8 mm. For high-risk patients, several interventionists use a single pre-op dose of LMWH at the beginning of procedure, although data on effectiveness of such prophylaxis is still not available. The little evidence is there to support prophylaxis, but routine prophylaxis may expose the cohort which is at low risk to potentially unnecessary side effects. In UK and Ireland, they had a high-risk VT, patients who were at high-risk VT, they said that LMW or prophylaxis should be given 1 to 2 weeks rather than single dose. In view of paucity of available data, there is no specific dose regime that can be recommended for this prophylaxis. Now with advent of DOACs, they are being increasingly prescribed because they are not injectables and there are early retrospective evidence which suggests that they are effective and safe and should be prescribed. However, comparative data with LMWH is still not there. For all patients, early ambulation and compression hosiery may further reduce thrombotic risk. Regarding other medications, which is MPFF, post-op there is endothelial cell activation or dysfunction, the vein wall hypoxia is there, shear stress disturbances, inflammatory reactions which have to be addressed, or free radical protection. So MPFF effectively lowers the effect of the various neurotransmitters in chronic venous disease. So how do they act is they block the inflammation, they block the signs and symptoms of post-op inflammation. They also induce better ulcer healing if the procedure was done for venous ulcer healing. And there was a very good study, which was the decision study, which said that there is a 3 times improvement in the VCSS score between only EVLT group as compared to MPFF with EVLT, which prevents vascular wall damage. And this is 3 times better in any venous procedure that has been done. So this study basically said that MPFF is of benefit for routine use in combination with varicose veins due to its vein-specific pharmacological protection. Overall physician satisfaction was also important, which said that if you use it for 4 weeks, then 2 weeks, the physician satisfaction also was more. And globally, they felt that in the perioperative period after intravenous procedures, this drug should be considered as appropriate for use in daily practice. Now, the most important is surveillance. that patients who undergo this procedure should be counseled for proper surveillance, and the first Doppler, follow-up Doppler, should be done 1 to 4 weeks after treatment. The next, various societies recommend various other follow-ups like 3 months, 6 months. This should be very diligently followed for preventing or diagnosing early recurrences if there is any. So these are the most important post-op guidelines for patient satisfaction of bringing in good results to the procedure that we perform, so that a patient should appreciate the overall holistic approach that the vascular surgeon may have. Thank you so much for your time.
Thanks, Tapish, for a very comprehensive coverage. We'll take questions towards the end. Next is, we are having an online presentation by Dr. Villaroyal. VCSS, the way forwards. Have you loaded the...
Hello everyone, this is Dr. Luis Arias. I am the president of the Bolivian Scientific Community of Phlebology and Lymphology. It's very glad for me to be invited once again in the 15th Annual Conference Venous Association of India. The topic I'd like to talk is about the CVI, chronic venous insufficiency, that can be assessed by venous clinical severity scores. The scores that we started to use it a few years ago is the CEAP code Z0, is not visible or palpable signs of venous disease. C1, telangiectasias of reticular veins. C2, varicose veins. C3, edema. C4A, pigmentation and or eczema. And B, lipodermatosclerosis and or atrophy blanchi. C5, Hilly venous leg ulcer. And C6, active venous ulcer. CVI, how severe is it? The individual factors that can lead to this condition have not been well described. Objective, to analyze a socio-demographic and clinical characteristic of a sample of patients with CVI to determine the factors that increase the severity of their condition. Material and method. A study promoted by the Spanish Society of Angiology and Vascular Surgery in collaboration with other scientific societies was conducted on 1,560 patients with CVI using two measurements tools: CEAP, clinical grade, etiology, anatomy, and pathophysiology, and the venous clinical severity score, VCSS. Results. The distribution of patients by clinical grade: Z0, 3.3%, Z1, 15.6%, C2, 21%, C3, 22.9%, C4, 23.6%, C5, 8.7%, and C6, 4.5%. The VCS score for the entire cohort was 0.89 plus minus 0.53, being higher the mean in 4 of the measurements attributed to pain, 1.59 plus minus 0.75, varicose veins, 1.8 plus minus 74.74, edema, 1.4 plus minus 0.89, and pigmentation 1.05 plus minus 0.98. Higher CEAP corresponded to higher VCS. In the subgroup analysis, risk severity factors were associated with male, weight, sedentary lifestyle, personal history, family history of venous disease. In the multiple regression analysis, the main determining factors were: 1 is the age, 2, history of superficial or deep venous thrombosis, and 3, patient's weight. Conclusions. There is a positive relationship between CEAP and VCSS. Subgroup analysis define strong and weak severity factors, which are revealed by multiple regression analysis. And once again, for me, it's a great pleasure to be in this conference in India. Regards to all my friends, Dr. Shahid Padaria, Zavul Jindal, Dr. Malay Patel, Dr. Roy Vardasi, all my friends in India. I have good memories for all you, my friends. And I hope I can see you next time in person, visiting India once again in person. Thank you very much. It's a pleasure to stay in this conference.
Thank you, Doctor, for a very nice presentation. We come to the last presentation of this session. I think Srikumar is not doing the presentation, is it? Okay. Medico-legal implications of venous disease by Dr. Das.
Very warm welcome. Last couple of days, more precisely last 2 days, we are talking and discussing about the various kind of medical problems and their way out, everything related to the medical science, technology, and how do we use it. Time has changed. Now doctors are not being treated as God. In India, last 15 years statistics shown 110% rise in medico-legal cases. It's mostly against the doctors. At the same time, institutions are also involved in all the medico-legal cases. So today, we are trying to draw certain attention of our clinical practice because we all do treat our patients with good intentions, but there could be some error, there could be some other things which may lead to non-favorable outcome. Media, politicians, and the social elites, everybody needs somebody to do something and to prove themselves that I am the right. If somebody is trying to do something, there might be certain amount of mistakes. But what mistakes is actually happening and what mistakes and where we are leading to, today's presentation is only for that. We have discussed a lot of issues that if we do any mistakes, then what will be the outcome differentiate, how we can serve the best. But is the society is interpreting in the same manner? The real life scenario is not like that. So we need to understand why everybody is talking about healthcare. If you go to the society, trainwala, dabbawala, politicians, media guys, everybody is talking about healthcare. I am not going to the details of what exactly health is, but I want to emphasize on the point. The health is a negative economy for each and everybody. It's a headache for the government, headache for the individual who is sick or whose patients or whose relatives are sick or admitted in a hospital. If we see the economic impact of disease, then it comes always in the negative economy. That means by providing healthcare, we are not getting anything. If I feel that somebody is healthy, that means that's the maintaining the baseline. If sick, that means they are coming down below the baseline. So our whole healthcare system actually designed to bring him back to the baseline, not above and over the baseline. So this is healthcare and where we do belong, and it is always a negative economy. So everybody, whatever is the amount, doesn't spend on his wish or he cannot get any kind of pleasure out of it. We can have 150 rupees of CCD coffees. We can have burger of 250 rupees. So it gives us feel-good factor. That's how this business is roaring up, but not the same in the healthcare. Yes, there is another concept of post-human as well as the transhumanism. We are not going into that detailed discussion. So where actually we stand today, if you see, 100 years back, patients came to the doctor and doctors is giving the best of possible treatment. Now the same scenario is there. Doctors are giving the treatment, but patients are not coming to the doctors. There are institutions or hospitals. It may be government hospital, maybe private hospital. We are not distinguishing government and private. So ultimate treatment will be provided by the treatment, but there is now a role of institution. Yes, we cannot avoid the role of institution, but all these institutions are basically a microeconomical scenario and definitely which will be dictated by the macroeconomic scenario. If it is a corporate hospital, definitely it is the profit of the owner, and if it is a government hospital, the profit of the politicians. These two kind of profit works in a different way. If it is a corporate setup, so their profit calculation will be in terms of money. But if it is a government hospital, their profit calculation will be how bigger society can be served and what is the political mileage in the vote politics, etc., is being served. So ultimately, doctors are leading nowhere and losing their professional autonomy. Though we are very proud about the professional autonomy, but believe me, there is no terminology called professional autonomy in any of the legal textbooks it is written. It doesn't exist. So how the healthcare system is being regulated? So there is, one is the preventive healthcare, then is the protection from the disease, that is the usual treatment where we do belong, and last but not the least, the research method. Whatever is the research scenario, every time science and research has been progressed, then there are many kinds of social debates, and after that some kind of regulation is basically control them. So we do cater. So our liability will be with the government, with the institution, institutional head, and at the same time to the patient that is the most talked for. So this is doctor-patient interface. Doctor is a person, patient is also a person. So both have a common ground of overlapping zone. If the patient is having medical problem, only they are coming to the doctors, not for anything else. So doctor-patient interface, it is a very important aspect. It's not because just the treatment and touching the patient and doing their proper treatment. It involves a lot of psychology, lot of socio-economic pressure, and definitely not but the least, the political scenario of the situation or whatever you say. So it is an overlapping zone, and there is definitely a huge gap of knowledge and expertise and the dissymmetry. Or otherwise, laws is always providing us and saying that we need to interact to make them understand. That's how informed consent came into the concept. It was initially information, then consent, then now it is the informed consent. So all the liability is basically thrust upon the doctors. If anything goes wrong, there is medical council, there is consumer forum, there is many other forum. At least one patient can lead us to around 8 to 9 forum. Single mistake or single complaint can be tried in 8 to 9 forum. There is a patient rights charter. It is in the Ministry of Health and Family Welfare. There are 17 rights written in Indian governmental patient rights of patient charter. There is nowhere written what is the right of doctors in any kind of law textbook, or even if you go to the Ministry of Health Family Welfare, there is nothing written. We do not have any specific medical law in India, so the diseases of venous disease and their management doesn't have any specific law or other implications. But in our day-to-day practice, we have to encounter with the CT, NGO, and MR, and most commonly the ultrasound. Even these two, whether we are being trained in not in gynecology and detecting sex, it is very difficult to say, but still our USG machine is under, at this moment, PCP-NDT. There are many kind of offense declared in there. Even one doctor can be pushed behind the bar. Jail, fine, or both. We are, at this moment, we are in the 15th annual conference of VAI, VICON. We are organizing the next 16th in Kolkata. I request you, invite you, come and join in Kolkata. Thank you very much.
Finished on dot. When the zero came up, you finished. Okay, the session is open for discussion. So we'll go topic by topic. Any questions on Professor Wool's presentation? This is the last presentation, isn't it? One more is there. Please start, sir.
So presentation is over. Yeah, finished.
The discussion is started, okay. I think Dr. Villarreal is on screen. Any questions on his presentation? Yeah. VCSS, the way forward.
This is Dr. Ilekma from Chennai. Excellent talk, sir. Enjoyed your talk. Sir, one small doubt is, VCSS doesn't take into account advanced CF. See, both ulcer or healed ulcer doesn't get mentioned in the VCSS score. Subsequently, we have the revised VCSS score, which take into account the ulcers as well as the intervention like compression bandages, which is more a dynamic scoring system. So is it not appropriate that we apply the revised VCSS score to compare with the advanced CF?
Well, a VCS score is just another tool to help us to take better directions in our treatment. We have different ways to have the better possibilities to have quality on quantity. It's just another tool that we can use to, to search a better way to do the treatment.
Thank you, sir.
Any other questions on VCSS topic? Okay, if there is no question, then we'll move on to Professor Wool's presentation. Any question on transosseous perforators? Any questions from the panel?
Is Professor Wool is there?
Okay, so we'll move on to Nihar's presentation. I have a couple of questions on Nihar. One, you mentioned about anti-TNF treatment. So what exactly is the medicine you're using here? And second is, okay, finish the first one. Second is, we covered only, regarding pharmacology, we only covered purified flavonoids. Any other pharmacology, you can suggest?
Yeah, actually, for any ulcer, like we have to pharmacology like antibiotic and anti-inflammatory. Along with that, MPMF that helps already. Dr. Tapis presented one of our my first DNV student, Dr. Nikhila. Her presentation was her thesis was the role of MPMF after post-operative treatment, and Dr. Tapis presented that. So any ulcer patients we give high dose. So like 1 gram, 1000 milligram once daily or twice daily sometimes also. That acts. And also like lymphangitis, like coumarin derivatives like this, lymphedema is there, that also helps sometimes.
From the audience, any other pharmacology we have tried? Because I personally, anecdotally, I've used stanozolol, I've used colchicine. So these are the other that we have been using, and I would welcome any views from the audience regarding other pharmacology agents which can be used. Is that?
So if
Pentoxifil, yeah, Trental, but it's not available now, this problem. Available.
So apart from the oral drugs, I think the new kid on the block for venous ulcers is the use of growth factors.
Yes.
In the last 3 years, we've done some good work on growth factors, especially the combination of epidermal growth factor in combination with chlorhexidine and sulfadiazine. And when we say it's a chronic venous non-healing ulcer, we define that as more than 3 months not healing. And our series, which we just presented recently in Dubai at the Weaven conference, shows that after starting with this local application, along with compression therapy of any sort that you may use, the complete healing, 100% of healing of venous ulcer at 3 months from the date of starting is as high as 71%. So I think this is something which we all need to actively look at. There are a number of companies in this country which have come up with this sort of a combination of 3 things: chlorhexidine, sulfadiazine, and epidermal growth factor. So I think this we should actively consider in all patients.
How do you use it? So what's the protocol for using growth factor? How do you use it?
Right. So growth factor you can use in various ways. It's basically an ointment which is available with a combination combination of all these three. If it's a very superficial ulcer, then we do a daily dressing on these patients. If it's a deep enough ulcer, you may use this with a compression stocking, a class 3, what you call an ulcer stocking, class 3 compression stocking, or give top grip bandages. And if it's an even deeper ulcer with very irregular outlines, then we use a 4-layer dressing. If it's of course a 4-layer dressing, we leave that ointment on for a period of 5 days. Otherwise, we change the dressing every day.
Any platelet-rich plasma like PRP therapy or stem cell therapy you give?
So we did try PRP therapy in our patients before the COVID era. We did about 45 patients in clinic itself with the PRP from the patient's own blood, obviously. Honestly, the results were it was as good as just giving compression therapy. So the added cost of another 30,000 rupees for PRP therapy didn't really make any sense.
Yes, Ilekma. Yeah.
Thank you. So to add on to Dr. Pedaria, sir, we used GMCS more than around 15-20 years back as a study. Here we don't apply the topical thing, we inject around the ulcer and then in addition to the standard care. But studies were not that impressive or significant ulcer healing because the wound factors or the receptors are already upregulated in any chronic wounds. So this doesn't much add on to whatever is happening. So it was introduced as Leukomax. There are plenty of studies there. Then it went out of vogue. Each vial cost around 5,000. So it was supposed to give four vials. So it was done 20 years back in MMC when I was doing my postgraduate. So I don't know. I have my reservations about growth factors, both topically as well as later on. I leave it to the panel.
Actually, I think Dr. Pinjala might remember, I think they even suggest using prostaglandins in treatment of venous ulcer. Sir? Pinjala, sir? I think there have been trials using prostaglandins which we use for ischemia for venous ulcers also.
The DNB students did the thesis on role of prostaglandin infusion therapies for venous ulcers which are larger than 5 centimeters. Not all ulcers. It was found to be beneficial. It shortened the duration of ulcer period and the responses were good. In conclusion of that is it can be used in selected group of patients, not in all patients. Patients should have no infection. Patients should have larger size. Patients should have been treated for truncal reflex. All those patients who were excluded, the remaining ones probably you can try prostaglandin infusion therapy.
Thank you, sir.
Is there any role for Lomodex? Say, there are some instances where Lomodex has been used, and a few of them have also used topical vitamin C solution and zinc solution. So is there any role for that?
Yeah, actually, that for any ulcer, apart from along with the venous ulcer also, we can use that. But there is no large study showing that. I searched that. A few instances they are using. So it is similarly acting like anti-inflammatory action so that the local swelling getting reduced. And another very important is, just now I told during my presentation, these patients' recurrences are very high. So we have to guide them that even if it heals, so that I used to tell them that once it heals, don't be happy. Again it will come back unless otherwise you take care. So what they have to apply some moisturizer, and if they have some chronic lymphedema like thing, they have to use, because sometimes patient is having some fracture histories there, some inflammatory inside there. So better to use some stockings whenever they are long standing or long sitting time.
Dr. Ramurthy, there is another medicine that is statin, simvastatin. There was a paper published from Philippines. So a small group of patients, 60 patients, and they found out the venous ulcer closure rate is very good with the add-on therapy with simvastatin. You can try that and you can read that paper published from Philippines.
This is a topic we can discuss one full day. So I think we'll go to the next session. Next topic, Tapish's presentation on post-op management. Is Tapish online?
Yes, sir, I'm here, sir.
Yeah, any questions to Tapish? My question is, you mentioned about prophylaxis and post-operative compression for eccentric compression. What sort of material you use? Post-operative eccentric compression, what do you use? Any particular material you have in your mind, you use regularly? Post-operative
Post-operative compression material.
eccentric compression. What, any choice of material you would suggest?
Sir, there are various elastic, inelastic things available, have been tried in various trials, but in India, we generally tend to use the compression dressing over the, eccentric over the vein, and then normal crepe bandage is what is being utilized here for around 2 to 3 days if they are not feeling the tightness. And then we open it after 2 days and put the patient on some elastic stockings or stockings with compression, which higher the compression, better are the results.
What sort of post-operative pain medicines your favorite combination?
So we generally tend to give them anti-inflammatory with MPFF and pain, specifically if there is a phlebectomy, then we have to give a higher painkillers like Ultracet, otherwise a Tramadol. Otherwise, we generally tend to do with some paracetamols that give both the effects to the patient. It also it depends on the varicosities that were, what was the size of the varicosities, and different patients have different pain tolerance. So on an SOS basis, we analgesics will do.
Okay. The last one is regarding choice of NOACs. Any particular NOAC you prefer, or you would leave it to the...
Sir, again, nothing is standardized, as I said. It is if we are giving in an OD dose, the rivaroxaban is fine because of better compliance and because of the other concomitant medications. So rivaroxaban is what is generally okay in those cases for prophylaxis. Otherwise, apixaban is also one drug which some clinicians tend to prefer, but it has a BD dosing. So that is just the no scientific evidence to say one is better than the other in these cases.
How long is the prophylaxis? How long do you give them?
So that's what I said in the presentation, that if the patient is a high risk, like patient has a history of some thrombophlebitis, if the vein was more than 8 mm, if the patient is a known thrombophiliac, or if the patient is obese, then papers say that up to 2 to 3 weeks of prophylaxis. Otherwise, if the patient is low risk, then a single shot prophylaxis with LMW peri procedure is fine. You don't need, if the patient is ambulatory with the compression hosiery, then there is no need to continue that in the post-op period.
Okay. So any question from the audience or from the panelists for Tapish?
Yeah, so the most common complication is thrombophlebitis following sclerotherapy. Though we recommend 1 week as the compression stockings, most of the patients, they have pain, extended pain even beyond 1 week. So the clear line of, what is the continuous compression which we need to have, despite even beyond 1 week, the pain still persists for many patients. So that's one controversial area. The other one is, what is your take on patients following Venous for truncal varicosities and Venous with foam sclerotherapy? What would be your advice?
Yeah. So Venous, the inherent property is that since it is just cyanoacrylate, so they themselves have not recommended any compression after that. That they say is the benefit of using Venous, pure Venous. But if you are combining it with foam sclerotherapy for the branches, then you will have to give compression with that. And actually, the phlebitis is not with the Venous, it is with the sclero that you are giving, basically. So if you are combining sclerotherapy, the standard regime follows. You have to give compression, you have to give anti-inflammatory. If it is a pure Venous, you can do away with without stockings or anti-inflammatory in that manner.
Sir, one more question, sir, if there's any time. Good afternoon, Tapishji, Dr. Ilekma from Chennai. Greetings. Suppose this patient, a hypothetical question, has an E-hit 1, 2, 3, 4, right? Grades. So what will be your regime in these patients? Anticoagulation regime, if any.
Sir, I couldn't hear your question.
E-H-I-T.
E-hit,
Yes.
okay.
Suppose,
So E-hit, you have already diagnosed E-hit on POD1?
yes, you do it
Okay.
routine.
So E-hit can be classified in four categories. If it is just coming to the junction, if it is going, having 50% of lumen, if it is going into the deep veins, deeper into that. So what the papers have suggested is 3 to 4 weeks of anticoagulation. If you have detected in 24 hours, 3 to 4 weeks of anticoagulation, they have found complete resolution of E-hit even with grade 4. So this is not as devastating if detected in time and treated properly, unlike the other DVTs. But you have to, that's why papers say that if possible, do on day 1 a Doppler to check for any thrombus that is beyond the junction, and if detected in time, then treat it. And complete resolution is found with a follow-up Doppler at 3 to 4 weeks.
For grade 1 and 2, do you still suggest 4 weeks of anticoagulation or just observation?
No. Grade 1, no. Grade 1 and 2, we will not suggest full dose anticoagulation. Grade 1, we will generally go with prophylaxis if we see that thrombus there. But yes, if the patient is high risk, that we have already categorized them into obese, if we have categorized them into thrombophiliacs, then yes, we will anticoagulate seeing a thrombus there, even grade 1 and 2. If it is a low risk patient where he has no specific history, then a prophylaxis will do. And they have found on day 3 and day 4 that it retracts and it comes back into the superficial vein.
Professor Khanna is, yeah.
Dr. Ajay Khanna from Varanasi. Can I ask Dr. Nihar?
Sir.
Dr. Nihar,
Yes.
in these patients, the venous ulcer, the MMP levels are very high. So do you suggest any treatment for the MMP?
Can you repeat, sir?
The patients with the venous ulcer, they have got a very high MMP levels. So do you suggest any treatment for the MMP?
Actually, those patients, apart from the other medication and the compression bandage, and we have to treat the venous ulcer, giving some anti-inflammatories, that also helps. And apart from the MPMF. Yeah, flavonoids.
There are some dressings which are available,
Yes, sir.
which are anti-MMP. So those dressings can be used for the venous ulcer. And then you can give the oral treatment also for them. And the doxycycline is a very important drug which counteracts the MMP. So these are the few other things which can be used for the venous ulcer.
Thank you, sir.
It's a very useful information, I think. So we come to the last presentation by Dr. Das for question. I have one question because now I have an ultrasound equipment which when I managed to get a certificate for the first time, they gave, when I went for the second time, they said you are not eligible because you are a vascular surgeon. So what is the current status regarding PCPNDT certification for vascular, for non-obstetric this thing? How easy is it going to be for vascular surgeons to get it? Because anesthetists are using it regularly, but we are still finding it difficult.
PCPNDT is the law governs the ultrasound use. And this PCPNDT is the machine specific and the space specific. Say for example, if you have an ultrasound machine registered for your diagnostic, officially you cannot shift this ultrasound machine even to your theater. So PCPNDT is a machine and space specific. At this moment, there is no demarcation whether you are a vascular surgeon or gynecological surgeon. So if you have to have a USG machine, you have to comply all the PCPNDT norms. Venous Association of India is trying to come with a sustainable solution, but it's not yet decided how far and how long.
So the same machine using for the echocardiogram by the cardiologist?
Yes, technology is the same, but probe is completely different. And Usually cardiologists do not use other probes apart from the cardiac probe. But licensing mechanism and the rules and regulation is the same for if you are using for vascular or gynecology or cardiology, whatever is the purpose. It is the registration of the technology. It's not for the probe.
Okay. Any observation from Roy, Malay, Pinjala sir? Because I think there was some discussion yesterday. They were mentioning this matter now sub judice. So I think something favorable should come out of. Huh? Sir.
And regarding this medical legal aspect for any doctors, the same thing is whenever we are seeing the patient in OPD, we have to inform them that what are the possibility of the results, what we are going to get.
Yes,
and
sir.
what are the other diagnosis modalities also, apart from the say varicose vein or peripheral arterial disease, what else are there? Because our patient used to have multiple factors, like Professor Wool told that phleboarthrosis with severe osteoarthritis. So they will have some lymphedema, like orthostatic edema also. So it won't vanish after varicose vein intervention.
Yes.
So that is very important to inform our patients during pre-surgery and post.
According to the law, it is informed consent, and consent is a term actually came from the Contract Act. But informed consent is a term coined to that kind of contract and consent. Informed consent came actually from the laws of tort. These laws of tort is something which is absolutely constant throughout the India. Whatever you are and wherever you are, you cannot devoid these laws of tort. So it is over and above any kind of law, whichever you can name. We do not have any specific tort law as we have Consumer Protection Act, Contract Act. There is nothing called Tort Act. It is laws of tort. It basically governs how a citizen should behave in the country, and it is not that kind of codified as in other laws. So informed came from the tort law, and we were helpless. We cannot bypass it.
Yeah, actually, many times patient accompany with one relative, and say they have, like in our city, so they say have 6 children, so accompanied by 1 or 2. Then again, after the next time, another 2 will come, we don't know, they will tell. So usually in the OPD, I write the, to whom I explain. So 3rd son or 4th son.
There are laws of tort, and when I was in law school, I taught 2 languages. One language is, if you know the law, then you can tort it. And if it is proven, only that is existent. So you need to be sharp enough to how to handle it. Say, for example, as you are a surgeon, if you are seeing a patient, ask the patient to declare whom you should communicate. And they may write 15 names, but don't say in that way. Say, in case of pre-operative investigation, if you found HIV positive, whom you trust most, that I can divulge the information to him. So now you will have only one guy to communicate, but make it official. So these are the techniques how you can modulate it. To modulate, you need to know the law first. Otherwise, it is very difficult.
Thank you. And we are supposed to finish at 1. We have finished at 12:45, so we are running ahead of time. Thanks to co-panelists and the audience for the participation. Thank you very much. It's a very eye-opening session.
Thank you, sir.
Thank you so much to our chairperson, Dr. Prakash Ramamurthy, our panelists, and all our speakers. Thank you for sitting here and enjoying the session. To all our dear audience as well. Give a round of applause to our speakers, to our panelists, to our chairperson, please. Thank you so much.